Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
We want to thank our following sponsors, themetabolicmds.com, a boutique weight loss practice focusing on weight loss through modern technology, the latest GLP-1 weight loss medications, and health coaching. We also want to thank the CGM Doctor, where you can purchase a CGM without a prescription delivered right to your door and also find useful information to get the most from your CGM to improve your health and weight.
Dr. Paul, guess what? We're back the week after Father's Day. I have no idea when this one will actually hit the airwaves, but did you have a great Father's Day?
I had a wonderful Father's Day.
And where were you on Father's Day?
I was in the emergency department for 13 and a half hours.
Way to spend time with your family, Dr. Paul.
I did get the obligatory call from all my kids, though, on Father's Day evening.
You didn't get a tie or a card? Or...
No, but they're all living out of town, so I got 3 calls. There's something in their mind that says it's Father's Day. I got to call Dad. So it was great. They all called me. I got to talk to all of them.
Well, it's great. Your kids called you. My kids live in town and then left town for Father's Day. That just goes to show you. All right. So you spent time in the emergency room, which brings us to the topic of the day. And the topic of the day, tell us the title of this podcast.
Rethinking your drinking.
All right. And that's because you've seen people over the weekend who are suffering from some kind of addiction to alcohol.
Right. And it's not only that. I mean, we get recurrent questions from patients and from followers, listeners here.
Yeah, we've had a couple,
on this topic. So it was time, I think, we spend a little bit more focus on it. And of course, my background actually, in addition to being board certified in emergency medicine and by the American Board of Preventative Medicine, I'm board certified in addiction medicine and, have treated opiate addicts and people with alcohol problems now for about 10 years. So, and when, just like metabolic health, when you can help guide some people, you can guide people to a better place. It's very satisfying. So I thought it was time we just kind of integrate these two topics of metabolic health and alcohol use.
Well, we've done a few podcasts in the past. We're up to like number 84 or something like that. But we've done a few in the past where GLP-1 is now considered a possible treatment for alcoholism, correct?
Yeah, it's not FDA approved for that, but it's being used, for patients that have alcohol problems that also meet criteria of obesity or some other medical problem. And, my anecdotal experience in my practice is that these are, medications there's no question they reduce alcohol use. Now, I don't know if it's because it's a specific action on alcohol or if it's just because people are eating less as well. They have an aversion to, food and fluid intake more than they used to. But there's no question in almost every patient that I take care of that's on GLP-1 medication, they're reducing their alcohol use as well.
So let's talk about that, because I'm curious, because my brother was an alcoholic and he took his own life, so it's very near and dear to my heart. If somebody walks into your door and says, I'm having trouble with drinking, and they've established the fact that they're probably an alcoholic, and by the way, what is an alcoholic and how you define one these days?
Well, we'll get into that criteria, and I'm going to give you here in a little bit the formal criteria for that. But let me tell you the definition I've arrived at over the years. I haven't heard this anywhere else. This is my own personal definition, and that is really, there's a problem with alcohol for anybody who is drinking more than they think they should be drinking. So very simple. If you're drinking more, no matter how much you're drinking, if you're drinking more than you want to be drinking, then that's an issue. And I'll give you a contrast. I literally have taken care of people that are drinking 10 drinks a week, and they think that's too much alcohol, and they want to make sure they aren't drinking more than 3 or 4 drinks a week, and we help them do that. And then I literally had a patient that was drinking about 35 beers a day,
Jeez.
daily. But he said it was light beer. So,
But do they know? Do most people know that come to you that said, "Yeah, I'm an alcoholic"? Or are they just in denial?
no, most the people that come to me are select. They select themselves. They know they need help.
Okay.
And that's why they come to me.
Yeah. All right. So they come to you. They know they got a problem.
Yeah.
You define kind of the issue. If you think
Yeah.
you're drinking more than you should,
Right.
then you got a problem.
Right. Let me give you the formal criteria, though. The
go ahead.
formal criteria is more than 15 drinks a week for a male.
And that's gin and tonics and crap like that.
Anything. We can get into what's considered a standard drink here in a little bit. But 15 drinks a week for a male and only 7 drinks a week for a female, because they process metabolically alcohol differently, and most of the time women are smaller as well. So it's unfair to the ladies out there, but if you go over 7 drinks a week,
And that could be a glass of wine.
yeah, glass of wine, hard alcohol, beer, it doesn't matter. So it's 7 for women, 15 for males. But then there's another criteria relates to the topic of binge drinking.
I don't know. So where does that?
Binge drinking is when, let's say you aren't, necessarily exceeding those criteria that we just met, but when you sit down and drink, you drink a lot.
So I don't drink Monday through Friday. I hit the weekend. I drink 15 drinks on a Friday night.
Yeah, that's binge drinking.
But I still stayed within my 15 drinks. So
Yeah, but again, there's a secondary criteria here that if you're drinking more than 4 drinks a week 4 drinks in a sitting for a female, or 5 drinks in a sitting for a male, then that's considered binge drinking.
5 drinks. Oh, wow.
And I'll tell you, I found that the semaglutide is especially effective in binge drinkers, because they just can't sit down and drink that much anymore.
So let's talk about, I walk in your door. I say, Dr. Paul, I got a drinking problem. What are some of the things you're going to ask me to do?
Well, you're jumping to the therapeutic end of things.
Well, of
okay.
course.
Well, we got to talk about the diagnostic end of things.
You wanted me to date you. I just want to get married. Come on.
Yeah, sorry, Terry. Sorry, Terry. But you know what? I'd like to talk about my experience over the weekend, which brought in the emergency department, which brought this topic up again for us to discuss.
All right.
Okay. So in the evening of the day was fine, but in the evening of Father's Day, I ended up seeing 3, trying to, finish my shift up, but 3 patients came in within an hour and a half of each other, all that were seeking detox.
Did they walk in the door saying, I'm seeking detox, or did they walk in the door in a situation and you talked them into detox?
No. These were people that came looking for help.
Okay.
So, and I'll just back off. This is a nuance that people will find surprising. But it's, people often expect they can just go to the hospital and get admitted for detox. But that's not always the case. If they don't meet certain criteria, even if they would benefit from detox, you can't always get them in the hospital right away. You got to schedule an outpatient thing.
What's the criteria?
Well, the biggest criteria, there are 2 main ones that you kind of hang your hat on. One is if their alcohol use is excessive and they're suicidal. You can't send people home that are drunk and suicidal.
All right.
Okay. And then the other one is if they have a history of bad withdrawal, what we call complicated withdrawal, which is generally a history of withdrawal where people get hallucinations or seizures, because alcohol withdrawal is life-threatening. So I think we've mentioned in this podcast before that, opiate use has got all the press and, how bad opiate withdrawal is. Opiate withdrawal is terrible, but it's not going to kill you.
An opiate is heroin, basically.
Heroin, yeah, or, oxycodone, OxyContin, fentanyl. But withdrawal from those drugs will not kill you.
But alcohol will.
Alcohol withdrawal is very, very serious.
Why?
Because the physiology is that alcohol is a depressant, despite the fact that sometimes people get crazy using alcohol. It's a depressant. It can depress your inhibitions, and that's why sometimes people get very active and conversational and all that kind of stuff. But it's because it's depressing your inhibition. So alcohol is a depressant. But then when it starts wearing off, all these autonomic nervous system things kick in. Your heart rate goes up, you start sweating, you can get agitated. So basically, when you take the depressant effect away, it can be life-threatening.
Are you ready to unlock your full potential? I want to introduce you to the Fit, Healthy, and Happy podcast, a powerful resource to transform your life today. With expert interviews, practical tips, and inspiring stories, this podcast is your roadmap to lasting wellness. Here's what a listener has to say.
I used to struggle with my health, but this podcast changed everything. It's like having a personal trainer, nutritionist, and life coach totally for free.
With over 2,000 five-star reviews, we're a podcast you can trust. The Fit, Healthy, and Happy podcast, available now wherever you get your podcasts.
Okay. All right. So, am I allowed to walk in your patient room yet?
No, let's talk. Actually, can I talk about my couple patients? At least
yeah.
I'm
Sorry. Keep going. Yeah. I want to be the guy who walks in your door.
So one patient I had on Sunday evening was a guy that just comes in all the time. He had 5 admissions requesting detox in the last 6 weeks.
What?
Yeah.
And is he turned away?
No, he wasn't turned away any time. He was admitted every time because he had a history of complicated withdrawal with seizures.
Wow.
So his alcohol level, I think, was around 330.
What does that mean?
I think legal intoxication in Ohio is 0.8 or 80. Okay. And so he is, 4 times normal drunk.
Okay.
I think my record over the years is like 525.
And what do they seem like when they're at that level? Are they coherent?
This guy is at that level so frequently that it's a normal conversation.
Wow.
Yeah.
Okay.
But this is a guy that, and he was an older guy. He was in his early 70s. That is just, quite honestly, a bit frustrating to take care of because you want to help him, but basically what he does is he comes in. He's having trouble, at home, I think, for a period of time managing his affairs. He just comes in and wants a break. And so he gets admitted for detox, stays for 24 or 36 hours, and then signs out against medical advice.
So he's coming in to get a break from drinking is what...
Yeah, he's coming in to get a break from drinking and just a break from his life at home and kind of get his thoughts gathered together. And
when he walks out the door, what's he like?
When he leaves?
Yeah.
Well, I mean, usually at that point, it's like, I'm leaving. If he's not suicidal and he wants to sign out against medical advice, he can do that. So,
okay.
The other guy was a little bit more interesting in that he was, 42, 43. He also had a history of complicated withdrawal, seizures and hallucinations when he was withdrawing. And in fact, he was a bit agitated, fast heart rate, sweating, pressured speech.
And what do you do when they're agitated? Are they thrashing out? What are they?
No, he was reasonable. He was cooperative.
Okay.
But just, very anxious.
Okay.
And I was worried about because we have this scale of alcohol withdrawal. It has about 15 items on it, and you can score their extent of withdrawal. and he was toward the high end of that. So, he was one I was concerned he was at risk for potentially having a seizure, which becomes a very acute, significant situation in the emergency department. So I wanted to pull him back from that. So I actually gave him IV medicines to slow, that process down and to get things under control.
Is that what you do with most of them that come in that want to be detoxed? You're giving them some type of sedative?
Yeah.
That's not alcohol based, I guess, or something?
Correct, yeah. Usually it's a benzodiazepine like Valium or Ativan or something like that.
And they're on that for a couple of days, and then they...
Yeah. You kind of bring them down slowly.
But you know that they're going to go back again. I mean, is it just a matter of time? Everybody's going to come back to
No, I mean, unfortunately, that's the standard, but there are people that break through, and they get detoxed and they get into rehab and they change their life, sometimes permanently, at least for a period of time.
I would like to talk to you about what goes on in rehab, because I have no idea. You hear people going into rehab, but you don't know what goes on.
Yeah, we can talk about that because I have an opinion on that.
Okay.
So let's go to that topic next. But this is the point I wanted to make on this second gentleman. So his alcohol level was 180. Okay. So
the guy was 3-something.
2.5 times normal or something like that.
Yeah.
And he was going into withdrawal with an alcohol level of 180.
And what the signs of withdrawal are?
We just talked about it. Agitation,
his like blood pressure's not.
No, his blood pressure. Sometimes it's even high because they're agitated.
Okay. But you say that's life threatening.
Yeah, potentially life threatening. But this is the interesting point with that particular guy is that he had dropped his alcohol to 180 and he was going into withdrawal. So what does that tell you? For him to stay out of withdrawal at home, his alcohol level was commonly in the 300 or 400 range.
Oh, I see what you're going.
Yeah.
Yeah. Okay. So
just by coming into, 1.8, 180, twice or more than twice intoxicated, by his alcohol level dropping into that range, he's going into withdrawal. So that's a bad alcoholic that you have to worry about.
And how long does you say detox is 2 or 3 days?
Yeah, well, generally, in the hospital, and then people then get...
do they see psychology or psychologists or therapy?
all that.
Everybody comes to the room and asks them questions.
All that kind of support. But you brought this up, so let's go there, okay? So I have an opinion on the inpatient rehab approach. So with somebody with complicated withdrawal, okay, they have to come in. The thing actually I failed to mention, we were going down this road a few minutes ago. Well, what occasionally happens if people aren't suicidal and they don't have a history of complicated withdrawal, presenting to the emergency department, they aren't, a lot of times, unfortunately, they have to be sent home to then be admitted on an elective basis, usually within a period of days. So there are people, unfortunately, that come in at times that are seeking help, but
you're sending them home.
I can't get them admitted to the hospital because they don't meet those criteria. It's the weekend. The rehab people are not taking people in over the weekend. It has to be a scheduled thing. So, that's bad because they're going to go back home and drink.
Do you follow up with them at all, or is it matter of fact once you send them home?
No,
okay,
we get them completely plugged.
Here's the number to call these guys.
Somebody's going to call them on Monday morning and start coordinating ongoing care.
Well, that's good.
That's good, but it's it's bad that people come in with the expectations of I'm seeking help. I want help. Can you help me now?
Right.
And the answer is, we can give you this interim support now, but I can't get you admitted to the hospital or directly into rehab.
Okay.
Yeah. So let's talk about this issue because I have an opinion on it of different types of rehab. So there's outpatient rehab, okay, which is just, working within a system, a doctor's office or whatever, mental health providers.
Right.
There's inpatient rehab, which we just talked about, that patient that has to get admitted to the hospital acutely because they're at risk for withdrawal or whatever. And then there's residential. okay, which is where people go where they sometimes will live for 90 days or something like that.
Like the Betty
Yeah.
Ford clinic.
Yeah, those different types of
Yeah.
clinics. So I just have an opinion that sometimes the residential stuff is way overdone.
You mean the one where they're getting checked away for 90 days?
Yeah.
It's way overdone?
Yeah.
Well, explain that.
Okay, so I think that limited amount of residential work is fine, but the problem with residential rehab at times, I believe, and this is contrary to what you're going to hear out there in the industry by a lot of people, is that the problem is when you're in this setting, you're protected, you're away from your stresses of your everyday life, and in that very controlled environment, you can maintain your sobriety. But then once you get discharged, you're back in your normal life with, family issues and work issues.
Yeah.
And that's why people relapse a lot.
So they don't do like a hybrid where you're kind of,
There is an intensive outpatient. What you're referring to is an intensive outpatient.
Well, I thought maybe you go
approach.
away for 3 weeks, and then as you start to...
And there's all those options, but unfortunately, I think the rehab industry has found that the residential stuff is the most lucrative approach for providing care to people. I don't know if your brother ever did anything like that, but it's like okay, let's go to Malibu and be part of a rehab program.
No Malibu, but
Yeah.
Amy Winehouse had a great song about the whole thing. I don't know.
Oh, is that right? I didn't know
rehab.
that.
Oh my gosh, she's one of the best artists ever, and she had a song.
Who died of an overdose,
She
right?
died of an overdose.
Yeah.
Yeah.
Not alcohol.
No,
but-
actually, I think she might have died of some complications of
alcohol? Or-
I can't. I don't know to look it up. 'Cause
Okay.
I love her. She's one of my favorite.
Okay.
She's fantastic.
I know who she is, but I don't know much more about that.
Yeah, okay.
So at any rate, so that rehab becomes a revolving door where, people go in rehab, they go home to the pressures of the world, and then, they start drinking again. And that's why I've really enjoyed the outpatient approach of working with people over a period of time, utilizing medications to help them in their real world situations gradually decrease their drinking. So I'm a proponent, and maybe we'll get into this in the next podcast, I'm a proponent of what's called a harm reduction approach. Harm reduction.
Oh, can you explain briefly? Then we'll cover it in more detail. What does that mean?
So harm reduction means not necessarily seeking immediate complete abstinence. Okay.
So you're trying to just reduce.
You're trying to reduce. And this is what I do a lot in my practice with the medications we use, naltrexone and now semaglutide, to help people gradually reduce their drinking to a manageable level. Because a lot of people come to me, and we can talk about this in the next segment as well. A lot of people come to me and they want to drink less, but they don't necessarily want to be abstinent. Okay, they still would like to use alcohol occasionally, but they want it to be much more controlled than what it is. They, believe it's becoming a crutch in their life. They believe they're beginning to have an issue, and they just want to be able to manage it without necessarily becoming completely abstinent. And quite honestly, I think that's a good approach. Not that they're continued drinking, but what I like doing is putting people in the position where we reduce their alcohol use over a period of time. So then they're put in the position of being able to become abstinent if they choose to do that. But if they want to continue to use alcohol at a much reduced level from what they were previously, and that's what they've decided they want to do, then I'm able to support that with medication and behavioral techniques that we use.
So why don't we land this, we'll call it part 1 of this podcast, and then we'll come back with part 2 right on top of this one, because I think we got more to cover that will be allowed to be on a podcast. So
can I make a plug for my addiction medicine practice?
Well, I would expect nothing else other than to make a plug for something. Go ahead.
So again, we take a medication-assisted outpatient approach to reducing alcohol use. where the goal can be abstinence or the goal can just be, limited use of alcohol.
Do I need to be in the area, or is this something you can do telemedicine?
No, so for this practice, I provide services in Ohio and Indiana.
Okay.
The name of the practice is North Dayton Addiction and Recovery Services. And, it's interesting. So this was, when I started this practice, it was at a time where, pre-COVID,
Sure.
There wasn't a lot of telemedicine going on. So we would see everybody in office. But now 95% of this practice is telemedicine, and it's not limited to people that live in the Dayton area. Now we can manage people, do labs, prescribe medications for anybody that lives in the states I'm licensed in for this treatment, which is Ohio and Indiana.
All right. So when we come back, I do want to poke at that a little bit just to find out how, sure, you can write a prescription for somebody and help them. I want to know more about the follow-ups.
Sure.
Right. Maybe you talk about how you do that, what's involved in the follow-up.
Absolutely.
All right. So let's land this one. Again, this has been the Metabolic MD with Dr. Paul Kolodzik. Today we're talking about alcohol and how to reduce alcohol. And what was the name of the title again? It's
Rethinking Your Drinking.
Rethinking. By the way, one topic I want to talk about, and I don't use alcohol, marijuana, or anything. Do people find going from alcohol to marijuana we'll talk about it later, but I think this will be a great topic.
Okay.
All right. We'll be back real soon. Thanks.
Thanks.